Why don't we go ahead and get started? We got some really good cases for you guys today. So missed one. There we go. And we don't have to make it through all these. I just want to make sure you guys have a good experience and learn some good things here. So anybody want to start off with this one?
Yeah, this is Chelsea from UT. I can go first. Can you hear me?
Yes, I can.
Okay, great. So we have a punch in this specimen, kind of at a global view, just looking, there's not really any epidermal changes. The thing that kind of catches my eye are these diffuse basophilic nests in both what looks to be mildly the superficial dermis, but the deep dermis and the subcutis as well. Looking at the basophilic nests, I don't really see any clefting around them. So the first thing that would have come to mind when I look at these that's more nefarious would be a basal cell, but I don't really see the clefting around the nests.
There's a little bit over here. So
Mhm.
that is a helpful clue whether you see clefting around the epithelium, between the epithelium and the stroma, and also, or whether it's within the stroma itself. Most of the little sort of clefts are located. What about the stroma? How would you describe that?
Still looks a little bit like it's kind of palisading around them, which does also, you also see in basal cells, but I think you also see those in trichoblastomas and trichoepitheliomas.
Yeah, notice the cellularity of the stroma. So it's got a lot of, it's pink. So there's a lot of type 3 collagen there. So it's not just, that loose fibromyxoid stroma that you see characteristically in a basal cell carcinoma. So that's a helpful clue to the diagnosis also. Because in a basal cell, there's a little tiny bit of that sort of fibromucinous stroma around this one little aggregation here, but it's generally, that's the predominant stroma that you see. So whenever you see something that is this cellular with a lot of fibroblasts and collagen, that should be a tip-off that it's probably more of a benign process than a malignant process. And the main thing that you are looking to distinguish here, obviously, is basal cell versus non-basal cell. So that's the most important thing. So you're in the right category. So it's epithelial is, benign versus malignant is the main question here. We've already talked about the differentiation. It's follicular, and it's probably, and basically of the type of follicle, you've got an infundibulum here. I'm talking about the portion of the follicles. There's a little bit of there's a cyst here, but the bulk of it is more kind of the, primitive inferior portion or the mantle zone area of the follicle. So that's the area of differentiation. So then when you're trying to distinguish between basal cell and non-basal cell, so you mentioned trichoepithelioma. Are there any other follicular tumors that you have to think about in the differential other than trichoep?
Trichoblastoma as well.
Good, trichoblastoma. Tell me a little bit about that. What does that mean?
So it's a benign hair follicle tumor. It's mostly from the germinative cells of the follicle for the trichoblastoma. And then some people think like a trichoep is a variant of the trichoblastoma, but.
Yeah, no, that's exactly right. It's basically, and Dr. Ackerman in his later years, he reclassified everything as trichoblastoma, and he said that basal cells were basically trichoblastomas. And, there's probably a little bit of truth to that in some way. There are neoplasms of the follicle, but I think there's some value in deciding whether something truly is benign or malignant. And I think it's, I don't know that they're ever going to change the terminology to that degree. So basically, when you're looking at a trichoepithelioma and this, notice how deep this lesion goes. It's much larger than most typical trichoeps. Most of those are usually relatively small. You can usually get rid of them with a superficial shave about this superficial. And then when you look down at the bottom down here, a lot of these are really, they're not really forming, they look pretty primitive. There's some little primitive papillary mesenchymal bodies, but they basically just look like sort of portions of the hair follicle that really aren't too terribly well differentiated. And so when we see something like that, that's sort of like a giant trichoepithelioma that may not have the little calcifications or small cysts and other things like that, then we call it a trichoblastoma. So they're in the same family. So did you think this was a trichoblastoma? Was that your ultimate diagnosis?
Yeah, just because it also cut, like you said, it went so much deeper and looked like it involved the subcutis. I was
Yeah.
favoring a blastoma.
Yeah, exactly. And so how do these usually present clinically?
Um, I believe they are mostly on the face and the scalp. They're kind of asymptomatic papules or plaques because they're like 1 to 2 centimeters generally.
Yeah, usually there's one lesion, and they often present like a cyst, interestingly enough, because they're like a dermal nodule. And so the clinician sees the patient and they say, that's probably a cyst. And they, try to incise it maybe, and it doesn't come out, or maybe they just take a punch of it or something like this. So it's often sent into us as rule out cyst. A lot of these adnexal tumors like spiroadenomas, hidradenomas, they're often just submitted from the clinician as rule out cyst, and they're often not cysts. They're usually something like this. And they often do occur in the head and neck area. But one interesting thing about these lesions is that they can occasionally occur in sun protected areas like the genital area. So sometimes you'll see, like in the groin and the vulvar area, the scrotal area, you'll get this lesion that's thought to be a cyst. They biopsy it and it's one of these lesions. How do these behave most of the time?
They're benign and they're asymptomatic from what I know about them.
Generally, yes. They can gradually get larger, just slowly over the course of time. Sometimes they can recur after you've biopsied them. So they usually get excised. We sort of tend to think of them as a low grade version, almost kind of like they behave like a very, very low version of a basal cell in a way. So you kind of think of them like a sort of a giant dermal basal cell carcinoma that's going to not really ever get too big and cause any major problems, but they can gradually enlarge and they can recur. So they usually get, treated like a basal cell, even though they're not exactly basal cell. But that's basically, it's a good example of it. And there's several different types of trichoblastomas that originally described by Dr. Terrence Headington a long time ago. There's another type that this one kind of is more like the trichoepithelioma variant. There's another type that's kind of got a rippled pattern. It's sort of a solid variant that has this kind of a rippling to the individual follicular elements to it that got some, pale collagen between the little rippled areas. So you want to read about some of the variants of trichoblastoma, you can do that. But it's just a nice, interesting example of another benign adnexal neoplasm with follicular differentiation. This is the inferior part of the follicle, or the area around the infundibulum area. Okay, anybody want to give this one a go? I don't recall. I think there might have been one area that actually had a diagnostic area in here, but maybe not. It may have gotten cut through. But anyway, you can at least take us through it.
Hi, Dr. Cockerell. This is Leah. I'm one of the Baylor first years. So this is a punch, and I see from this magnification, at least minimal epidermal change that's obvious right now, but I see some superficial and deep infiltrate, perivascular certainly. I see some dermal edema. So I go down the inflammatory pathway, basically.
Good. Excellent. What kind of cells do you think we're going to be dealing with here?
So I already, from this view, I already see some lymphocytes. And then I think on other, so yes, I see some eosinophils. I see some neutrophils. So kind of a mixed infiltrate.
Yeah. So what's the classic pattern? And also note, you said superficial and deep. Can you tell any difference between sort of the density infiltrate at the top versus the bottom?
Yes, certainly at the interface in the DE junction, there's a lot of interface dermatitis, and it becomes less dense as you go down.
Yeah, I'm not so sure I'd talk a whole lot about the interface changes. I agree with your papillary dermal edema comment there, but interface really should have vacuolar alteration or lichenoid. There's this one little area here, but you're exactly right. Notice that it's deeper. It gets less deep as you go, less dense as you go deep. So it's kind of got a wedge shape to it. And there's a reason that it's wedge shaped. What's one possible reason that something might sort of be wedge shaped in a way like this for the inflammation? Let's say if you,
I'm not sure.
if let's say you put a drop of some kind of a chemical here and it gradually diffused from the top of the skin down to the bottom, it's going to have a higher concentration at the top than it is at the bottom, right? So it's going to be, you're going to get more inflammation up here and less inflammation. And then finally at the bottom, it trickles off. So that kind of makes you think that, well, something may have stimulated this. Like down here. Yeah, like say maybe, what's the classic pattern of a superficial and deep perivascular interstitial mixed infiltrate with eosinophils? It's wedge shaped. What's the most common cause of that pattern in dermatopathology?
I want to say like an arthropod.
Yeah, you want to say exactly correct. You said exactly right. And now, so that's what this is. Now for bonus points, can you see something right here? This is difficult to preserve because we're trying to cut some, teaching sections, but in the original section, there was an actual, this has got a little, if you were to polarize that, it's polarizable. It's kind of got a chitinous component to it. And notice where it's located. So where is it? Where am I pointing to right here?
The stratum corneum.
Yeah, just beneath the stratum corneum, just the very outermost level of the epidermis. So what organisms can attack that area?
Like a tick?
Well, a tick could, but usually a tick bite's going to give you a deeper, we often see like a kind of the collagen gets degenerated there with some very pink eosinophilic material that has to do with the tick enzymes that it injects into your skin, and it actually causes a cement reaction that forms. Interestingly enough, it makes a glue because that's how it attaches to your skin. It actually causes collagen degeneration, and then it just sucks the blood out of that area and it attaches there. So you'll see something down in the dermis, usually fairly deep, about this area. This is just focal right up here, just beneath the stratum corneum. And there's a few organisms that like that area. What's the most common one that we think of in dermatology?
Scabies?
Yes, scabies would be the first one that you would think about. But that doesn't really look like scabies, does it?
No.
No, it doesn't. What are a couple of other things that you might see that live in that area?
I think maggots.
Those go deep. They also form a channel down in this area. So if you ever see like a botryomicosis, I mean, that's or not, I'm sorry, not botryomicosis, but bot fly, that gets way down in this area. Myiasis. So that's a different deal.
Maybe like Demodex?
That lives within hair follicles. So that it can sometimes kind of look like that if you're kind of adjacent to a follicle. There are some other non-scabetic mites that you can see that don't really burrow into the skin, but they'll kind of live right in that area, like the bird mites, for example, or mites that are in the brown grocery bags, cheese mites, those kind of things. Those will involve this area of the skin. And then there's this entity, which is, you're not going to be able to tell what this is here, but what if this person had been, was like a hunter and they'd been out duck hunting? And you know what, I don't know if you guys ever go duck hunting, but you got to get out early in the morning and you wade out into the water and you sit there with your camouflage on and the ducks fly in and it's cold and miserable and all this, that, and the other. And sometimes you leave and you go home and you got an itchy dermatitis on your skin.
I'm not sure.
That's there's two things. There's like cercarial dermatitis, which is there's two things. There's sea bather's eruption and swimmer's itch. They're two different things. Sea bather's eruption is when you swim and the little nematocysts of jellyfish that are little teensy tiny larval forms migrate onto your skin and they bite you, and they're not really biting, they're just attaching to your skin, and they occur in areas where you don't have your swimsuit on. And then swimmer's itch is a freshwater cercarial dermatitis, and that's usually in a situation where ducks are located because the life cycle of cercaria goes through the duck and it gets into the water. And so that's commonly seen with hunters, and that's almost actually underneath the clothing, because you get your clothes get wet, and then these things kind of just sort of seep into your skin, and it gets in there, and you get this itchy dermatitis, often where your clothing actually was present, that where it was wet. So this actually was someone that actually had been doing that. This was an example of swimmer's itch, and that's a little tiny piece of the cercaria that's left there. So the original section we had, you could actually see the little mouth part of it. I mean, it was really, really cool, but unfortunately we just have a little tiny bit of it that's left. So you wouldn't be able to tell that here. But the main thing is, if you saw this was an arthropod assault reaction, that's the key, because this is a classic example of that. Actually, here, look at this one. Oh, here it is right here. Can you see that?
Mm-hmm.
That's the little mouth part, and there's a little crust that's beneath it. There's the little cercaria that's living right there in that little burrow within the skin. It was here on this one. I thought we couldn't see it, but we can see it. So that's an example of a cercarial. And look how this actually goes all the way down into this area. So it's not just only here, it's kind of gone on down through the epidermis. So that's really cool. I hardly ever see that, just so you'll know. That's just a really rare thing to see. The board's not going to show you that. But the main thing is just to know the pattern. So superficial and deep wedge-shaped eosinophils, papillodermal edema. If you get striking papillodermal edema and you get a secondary blister, that's often seen in patients that have some kind of an immunocompromised situation. So you have to remember that. May have a lymphoma or something like that in their history. So that was swimmer's itch or cercarial dermatitis. Okay.
Okay, so we have a punch here. And looking at it, it looks like, the primary process of what's going on is located in the superficial dermis. And it looks like it goes, kind of right up against the epidermis too. So there's not like a grin zone or anything like that.
Good. How would you describe the pattern here of involvement?
I would say it's almost kind of maybe like nodular in a way.
Yeah, it's got some nodules here, and they've kind of coalesced, so it's pretty diffuse, isn't it?
Mm-hmm.
And it goes, you're right, it's really mid-reticular dermis. It's not all the way to the bottom, but it's kind of getting in the deeper part of the dermis. It's not just like a little superficial perivascular dermatitis like a viral exanthem or pityriasis rosea or something like that. This is going to be a pretty dense infiltrate that's probably going to be an infiltrated lesion clinically, right?
Mm-hmm.
Good.
I agree. It is definitely very dense. You notice some areas that are light, some areas that are dark. The epidermis itself looks pretty thin. I think looking at the cell types, there's also some fibrosis that you can note though from this far away. And as you zoom in, some of the cell types that I had noticed was that there are lymphocytes. I noticed lots of plasma cells. And then I think the main thing that stood out too was like these histiocytes.
Good. Good. That's the main thing. So even at low power, you said that it looks kind of light. So you say, gosh, there's probably be some histiocytes in here. And then you go to higher magnification, histiocytes predominate in a number of areas. So what do we think about when we see predominance of histiocytes?
Yeah, so some things that I think about with predominance of histiocytes are, especially if they're weird looking, you can think of like that rosé Dorfman. Other things would be like the multicentric reticulohistiocytosis. That typically has like the ground glass kind of two-toned appearance of the histiocytes. And then there's things like, granulomatous reactions, something too with like histiocytes and plasma cells too. I always just kind of throw on the differential is like syphilis.
Yeah. So in other words, an infectious disease also. So whenever you see granulomatous inflammation like this, especially if there's suppurative granulomatous inflammation, you obviously would want to think about an infection. There's also this area here where there's some pseudoepitheliomatous hyperplasia. Now, this isn't as prominent as we often see, but there's definitely some in here. So good. Those are probably the main things in the differential diagnosis. Now, I don't recall if we could actually see organisms in here, but if you wanted to look for organisms, because on the board exam, if you get something like this, they're going to show you something where you can see the organisms pretty quickly with routine H&E, or they're going to give you a special stain to look at. So if you want to look for microorganisms, where are the best places to look?
So you can look like within the histiocytes?
Yes, look inside the histiocytes. That's helpful. If there are any in the areas where there's suppuration, look in those areas, especially if there are any abscesses in the epidermis, because the organism gets transepidermally eliminated from the through the skin. So that's another place to look. So that's what you would want to look for. And this one, it's the answer here is that this was an infection. It says it was a deep fungal infection. I don't know which deep fungus it was. It might have been blasto or something like that. But basically, just to show you, this is the pattern that you see when you see this granulomatous inflammation that's like this. You want to think about the things that you mentioned, and certainly an infection is high on the list. So given that you're going to be asked to probably identify organisms, make sure you know where to look. You want to always look inside the multinucleated histiocytes. If there are any suppurative foci, look in there. And then any abscesses within the epidermis, look there. So again, I don't know which, it just says basically deep fungal infection. So basically the idea here was just to show you the pattern here. And then we couldn't see which organisms was causing this. Okay, any questions about that one? Good job. All right, we'll try this one.
Okay, so it looks like we have a punch. In terms of where we are on the body, this looks pretty nonspecific, so maybe somewhere on the trunk or the extremities.
Excellent. Yeah, that's exactly right. I think this was the trunk in this case.
It looks like most of the action is going on in the papillary dermis.
Good.
We see this focal, like ball-like collection of an inflammatory infiltrate. From this power, I can't tell which cells, but I think that they're lymphocytes.
Yeah, no, you're right. They are lymphocytes primarily. What you said, ball kind of morphology.
Mm-hmm.
Elaborate on that a little bit. What were you sort of thinking about there?
The infiltrate is it's very like focally confined to that area, and there's the epidermal reedy ridges are they're kind of almost like hugging it, or they're kind of encasing it almost.
Like a little ball claw-like morphology.
Yeah.
Sort of.
That kind of morphology makes me think of something like Lichen-nitidus.
Okay, so that's what I knew. That's what you were thinking. Why is it not Lichen-nitidus? At this power.
At this power.
So we just saw the case of the, deep fungal infection a second ago. Even at that power, you could see that those cells were pretty light, histiocytes. Mm-hmm. So what's the pattern in Lichen-nitidus? What's if you wanted to just describe it with no slide there, what would you tell somebody?
You would see a collection of lymphocytes, focal ball in the papillary dermis.
Well, are they really lymphocytes in Lichen-nitidus? Is that really the cell primarily there?
You also can see sometimes some multinucleated giant cells.
It's classically a little focal. Yeah, it's usually granulomatous. It's usually a focal aggregation of histiocytes. So it's mostly histiocytes rather than lymphocytes. So that's what really helps you to distinguish those two. So you do have a little, probably focally lichenoid infiltrate here that's just got this epidermal hyperplasia surrounding that's kind of simulating Lichen-nitidus. But it's not purely that. You can see it's also perivascular. And also, if you look here, that's probably a little eccrine sweat duct here. Mm-hmm. And there's a little bit of, you can see it's kind of trying to track down this eccrine gland here a little bit. It's not in the deeper eccrine units. That's something that would be nice if it were present in this case, but it's not there. So it's kind of really more of a focal lichenoid infiltrate, but Lichen-nitidus would be the thing in the differential with that pattern you're talking about, but that usually, think of that as being a focal granulomatous infiltrate with a ball and claw morphology. And usually they've got, 2 or 3 of those or more in the same specimen. It's not diffuse over a broad front. You might say there's one here and there's one here. And clinically that's what you see. You see little tiny papules, and then and they're kind of yellowish. And that makes sense too, because they have mostly histiocytes in the infiltrate, or whitish.
Mhm.
So probably not lichenitis. So if it's a focally lichenoid infiltrate that's tracking down the sweat glands, does that bring any other potential entity to mind? Since we
Like
threw that.
lichen striatus.
Yeah, lichen striatus. Good. Excellent. That's what this is, actually. It's not as good an example as it could have been, because if we really had a good case of lichen striatus, we'd see the inflammation down here. But lichen striatus is one of the conditions that gives you a lichenoid dermatitis. Focally lichenoid infiltrate can give you some variable amounts of spongiosis, can give you rarely some dyskeratotic keratinocytes in it. And there's a variant of lichen striatus. What's another entity in the sort of spectrum of lichen striatus? What if we saw this patient and they didn't have a elongated linear scaly plaque going down their arm? They had kind of a zosteriform scaly plaque on the right side of the trunk, for example. What would we call that? If it was following the lines of Blaschko.
Oh, like like the epidermal nevus, right?
Or Blaschkitis, which is
Oh, okay.
It's a variant of lichen striatus. I'm a big lumper, and so I sort of think of them as being the same entity, but the textbooks will separate those out. And if it sort of looks more like an epidermal nevus, it kind of looks like it's following the lines of Blaschko, then, and shows this histology, then you call it a Blaschkitis. If it's more of the linear pattern that's, kind of going down to the finger or whatever, then you call it lichen striatus. So, but it's basically the same histology. And it's usually more of a lymphocytic infiltrate. You might get a few histiocytes there. And again, you can get a little bit of spongiosis, a little bit of thermal hyperplasia like we see here, maybe an occasional necrotic keratinocyte. This is it's a reasonable example of it. The only thing we really would like to have is more of the eccrine involvement. Maybe the fact that it's not involved in the eccrine favors the Blaschkitis more than the lichen striatus, but I've seen plenty of cases of classic lichen striatus that didn't really have a lot of that too. So that's good. Okay, good. Well, that's good there. Good description and good way to work through that. Okay, this is a good one also.
I can go next. This is Jamal.
Great.
I see a punch biopsy.
Good.
Looks like, don't really see like any features of a specific site, so maybe trunk or extremities.
Yeah, exactly.
The epidermis looks fairly unremarkable. Looks like, fairly normal. And then kind of from a bird's eye view, it seems to be pretty thick collagen bundles within the dermis. Doesn't have like quite like the squared off appearance to the punch that you can see in some things, but and then seems to be a little bit of superficial, like a sparse superficial perivascular infiltrate.
Yeah, it's pretty subtle though, and really not much.
Yeah, not much. It's like very sparse.
So this one's, when you look at it, you say, gosh, there's really not a whole lot going on here. There's not much inflammation. If you biopsy somebody's back, if you go out to the VA hospital and biopsy those guys' backs, they all look like this. So it's probably within the realm of normal. It's not really sclerotic collagen. So this is just kind of a variant of normal of the collagen. But what if I told you that clinically this guy, or let's say you say, well, gosh, it doesn't really look like much. And I look down at the pathology requisition form and it says brown, scaly, crusted material on the guy's chest, rule out, some kind of a pigmentary disorder. And then you saw this. Now, what does that bring to mind?
Like carp?
Tell us what carp is.
Was it Confluent? I forget the exact name. Confluent something reticulated papillosis, I think.
Yeah, confluent and reticulated papillomatosis of Gougerot and Carteau. And so when you look at that, the name is actually pretty good because it's clinically, it's confluent. You know, when you look at the patients clinically, they kind of have this sort of, it's usually the chest area, sometimes the back. The chest is this, that sebaceous lobule, maybe because it came from the chest, which is a sebaceous area. And it looks reticulated clinically, kind of looks like a network. And it's papillomatous, and histologically, this is papillomatous. So that's the thing to kind of recognize here. Normally, if you just biopsy somebody's chest or back, this is actually not totally normal. This is one of the epidermal reticulated pigmentary abnormalities, if you will. And there's actually about 5 or 6 of those entities that you kind of need to at least know about. And so this is one of them, confluent reticulated papillomatosis. This is what it looks like. The epidermis is it's papillated, thrown into these little folds here. It's brown, as you can see, which correlates with the brownish color clinically. And a lot of these patients are maybe even type 1 or 2 skin. They don't really have dark skin types, and they get this. So that's, you can see that's really it is hyperpigmented. And it's kind of got the reticulated part is more the clinical. You really wouldn't see that histologically. But this is what it histologically looks like. So it kind of looks like a nothing diagnosis. So again, if you see this on the board, you say, well, gosh, you know, it doesn't look like there's much going on here. Is it possible that it's an epidermal process? And if you get the right, you know, information, it's probably be more of a multiple choice type of situation. I don't know, they would expect you just to pick this out of a lineup with nothing else, no information, but you should at least know this is what CARP looks like. Now, what are some other entities in the family of the reticulated pigmentary epidermal disorders besides CARP? What if we saw some acantholysis here? And this may be more of a 3rd or 2nd year question. If you're a 1st year, you might not know this yet, but
Like Darier's or?
Well, there's another entity where you get the same sort of, you know, epidermal hyperplasia and papillomatosis, but you get foci of acantholysis in there. Clinically, it doesn't look acantholytic at all, but histologically, you see it.
Oh,
Somebody's put in the chat, I think.
golly, I have never
Yes,
heard.
golly disease. You have now. So you have now. So good. You've added to your encyclopedia. You got a new term there. That's called golly disease, not GOLLI. It's GALLI. What are a couple of other things that you have to think about? You may not know. You may want to get some help from others.
Yeah, I may have to ask for some help.
Yeah, chat. Yes, Dowling-Dago's disease, also known as reticulate pigmentary anomaly. There's several other entities. You also think about acanthosis nigricans. That's in the differential diagnosis here. Kitamura's disease. There's another one called reticulate pigmentary, acral pigmentary abnormality of Dohi, D-O-H-I, I think it is. So there's several of those. I'd recommend just reading the text on those, learning about them. Probably aren't going to get a lot of questions about them on the boards, but they're easy to know. They all kind of look the same. And it's an easy point if they do ask it on the exam. So just understand that basically the concept here is that you get this epidermal abnormality, and acanthosis nigricans is probably the most common one. And that's usually more papillomatosis, more parakeratosis than that. But that, as you know, is associated with underlying carcinomas and things. So you very well might get a question about that, at least somewhere on the boards, about acanthosis nigricans. Okay.
I am next. This is Ashley from UT. I'm one of the 1st years.
Okay, great.
So we see a punch here, probably on the face because of the amount of adnexal structures and fat closer to the surface.
Good. What else? What else makes you think it might be the face here?
We have like tons of solar elastosis up
Yeah,
there.
exactly.
Unexposed area.
How old do you think this person is?
I think this individual might have collected a few years in their life.
Yeah,
I think
been a couple of days out on the beach over the years, right? Or playing golf or whatever.
Mhm. A
So,
Florida golfer.
yeah, it could be man or woman, you think?
Um, I honestly don't know, but hmm.
You may not be able to tell from this. If it's a man, they would probably have more sebaceous lobules and maybe some, larger hair follicles down in here because, they're got a beard and they're shaving and everything. There's one other clue that it might be a woman.
There is something that is in the deep section of this punch, some like amorphous structure that's like encased by blue inflammatory cells.
Yeah, good.
Um,
So this is an inflammatory process or a neoplastic process?
this is inflammatory.
Yeah, inflammatory. And you're right. There's something. So what do you call this? I mean, what do you say this amorphous material? Do you think this is endogenous or no?
This is a foreign body.
Yes.
Doesn't look like something naturally occurring.
Good. This is foreign material. And any idea what foreign material it might be?
Either filler or topical or like injected steroids is what I was looking for. It
Okay.
looks
So
like
now
there's some bubbles in
the
there.
board, you might get this on the exam and they might have a list of choices there and they might say steroid and Kenalog. Does Kenalog look like this?
I don't think so. I saw like one photo with it, but it didn't have all these like blues. It didn't have like all these like lymphocytes around it. It had like more of like sclerosis around it.
Yeah, if anything, when you inject Kenalog in there, if there's histiocytes there, it's because they were kind of there beforehand and you're injecting the Kenalog to try to, decrease the inflammation.
Yeah.
So intralesional, inject intralesional Kenalog into like a keloid or something like that. It usually doesn't have any inflammation around it because it's an anti-inflammatory process most of the time. If you're injecting it like into a cyst of acne or something like that, you might see some suppurative granulomatous inflammation. Then you're trying to decrease the inflammation, usually right around the Kenalog. There's not much inflammation there. And those give you the crystals. They're little crystals and it's kind of got this kind of, I'm going to say kind of pinkish white kind of color to it. Looks different than this. What color are we looking at here?
This is kind of a purpley blue.
Yeah, it's kind of grayish purple, I would say. Yeah, I agree with you. I like to think of this as bluish gray jello,
Mm-hmm.
if you will. And so you said filler. Now that there's, when you're in the cosmetic derm rotation, if you say filler, they're going to say, well, which one? Which one do you want to inject into the patient? So what are some fillers that you have in your menu of options that you can use for patients that want cosmetic rejuvenation of their skin?
Like hyaluronic acid.
Yeah, hyaluronic acid, Juvederm, those things. And when you look at that under the microscope, what does it look like?
Like kind of bubbly, or is that the silicone?
You're looking at it. It looks just like this.
Like this. Okay, like this.
So think it looks kind of like blue-gray jello. And they're often actually they often kind of fracture in the skin, interestingly enough. That's hyaluronic acid. So basically, if you look at your normal hyaluronic acid in somebody that's say got pre-tibial myxedema or in, focal cutaneous mucinosis or digital mucocyst, it looks the same. It looks just like this. So this is just some that was made in the laboratory and then they injected it into the person in a high concentration, trying to get rid of the wrinkles. So this is more likely a woman than a man, just because men don't get filler injections as frequently. And this is what it looks like when you biopsy it. And this is what happens when you get an occasional reaction to it. Now, it's not that common. Most time when people get filler injections, they do fine and they don't have any problems with it. But every now and then you get somebody who gets a granulomatous filler inflammatory response. And this is what it looks like. It kind of is palisading around the filler. So it's interesting. Now, what else might they put in the differential diagnosis of this to try to trip you up?
Something to trip me up. Like another foreign body reaction? Or are you thinking more of like
They might, but there's one other thing that they might put on there that sometimes can give you very commonly actually will give you a palisaded granulomatous reaction around the foreign material, but it's really endogenous material that shouldn't be in the skin that ends up in the skin because the person's got a disease?
Some kind of like cystic thing.
Well, I was just, it's the old play this game of read my mind, but basically gout crystals. So if
Oh.
somebody gets a tophus, they can get these wispy, kind of slightly bluish colored crystalline material where most of the gout crystal has been washed out with the alcohol in the processing of the tissue. And you get a granulomatous reaction around that. And that can sometimes give you kind of a slight, the color can be a little bit similar to this. You get little crystalline structures there though, and you don't get, they're this wispy, feathery kind of appearance, not this sort of homogeneous blue-gray color that you see with hyaluronic acid here. So that's a filler. So make sure you know some of the other fillers. Methyl methacrylate, that those look like little BBs. Radiesse, that's got the calcium hydroxyapatite, and those look like little calcified balls in the skin. So they look different. If collagen that gets injected is more pink and eosinophilic, I don't even know if anybody's really injecting collagen much today. Seems like it's mostly Juvederm and some of these other fillers that get injected. You really can't see as much of it on this side, so it's really on this piece over here that's got the action. So I'd recommend learning about your fillers because they're big and you do get reactions to those. I think I showed you a case of silicon maybe last time or a couple of times ago. So make sure you just know the various foreign body reactions in the skin. Okay.
Okay, good morning. This is Usman from Baylor. So this looks like an excision, and just looking from this power, I would favor, I think, a neoplastic process.
Good, excellent.
Looking, I see kind of this diffuse proliferation of these basophilic cells, all in the superficial deep dermis, extending down to the sub-Q. They don't really seem to be organized in any sort of well-circumscribed pattern. Just looks like a diffuse kind of.
It's a fairly diffuse process. We don't really know how big it is, but because it goes to both sides. If we were going to draw a line or a circle, though, you could kind of, it's not sort of going everywhere. You sort of says, well, it's probably a pretty big lesion, but it doesn't seem like it's really going diffusely into the fat all the way to the base. It seems like it's kind of got a limitation to it, if you will. So we're not going to say for sure whether it's benign or malignant at this power, but we say, well, it certainly doesn't look very super asymmetrical. If we drew a line down here, it pretty much looks the same from side to side. And, we're not sure about the circumscription. It is pretty large, but it doesn't really look anaplastic at low magnification. It seems like it might be benign. So let's talk about what the differentiation is here with a little higher magnification. Do you think it was epithelial or non-epithelial?
Taking a look. Well, I see it has a very granular look to it, and then the nuclei seem kind of centrally located and dark purple, surrounded by these fibrous septae.
So you probably know the diagnosis, right?
I would think so. I would favor a granular cell tumor.
Yeah, this is a granular cell tumor. Is it a malignant granular cell tumor or a benign granular cell tumor?
I would say benign.
And why?
Well, I'm looking for things like atypia or mitoses. And I could be wrong, but I don't seem to see much of those features.
No, you're exactly right. There's no cytologic atypia. There's no pleomorphism. There's no mitotic figures. And it's one of the issues with granular cell tumors is that these things can be very large. When you see them clinically, they can be almost the size of a golf ball. But just because something is large doesn't mean that it's malignant. We see lipomas that are huge and large dermatofibromas on the ankle that can be several centimeters in size, are still benign. So just because something is big doesn't mean that it's malignant. It is one of the cardinal architectural features that we get concerned about when something's large in the skin, that it might be malignant. So we always put the brakes on. But then when you sort of say, well, gosh, it's big, let's look at some of the other ancillary features, we do exactly what you did, and you decide whether it's got these other cytologic features, and here they look totally benign. So I totally agree with you. What is the is this an epithelial or a non-epithelial lesion?
Yes. So
And, you know, sometimes
how
it's
does the
tricky. You kind of have to know
Uh-huh.
what the situation is. Or what's the differentiation of these cells here? What's thought to be the differentiation of the granular cell tumor?
well, I guess
You
I
may
guess I'll
not
say
know. If you don't know, that's
yes.
okay.
I'm
But
not
it's actually
totally
in the
sure.
family of the so-called neurocristopathies. They're thought to be Schwannian in origin. So it's really more neural. And so and that's really, you know, non-epithelial. So it's really
Right.
basically a neurocristopathy. It's the Schwann cell origin. Now it's interesting. One other thing about granular cell tumors is that they actually, you can get granular cell changes, granular cell reaction patterns in non-granular cell tumors. Granular cell angiofibroma, for example, in the nose. You get granular cell change sometimes in leiomyomas. Granular cells can be seen sometimes in atypical fibroxanthoma. So you can get a granular cell reaction pattern also, which is interesting. This is just a regular old granular cell tumor in this case. And if you wanted to prove the diagnosis, there are two stains that you could use. Any idea what those stains are?
I think you can use PAS. It's PAS positive.
Yes, PAS is a classic one. And then, of course, what's another one that you could use, given that it's a Schwannian?
Schwannian. Would we think like myelin basic protein or PTAH, the
I probably would just go with
acid?
probably not PTH, but that's more for fibrin. But I would go with an S100 protein stain, which is strongly positive in this. So that'll stain nevo, melanocytic, and neural lesions. SOX10 would probably be positive here as well. What are just a couple of quick things about this before we move on? Notice the skin here is dark. What ethnic group is predisposed to develop granular cell tumors?
Well, I think darker skinned individuals,
African
maybe
American.
African American descent.
Yeah, it's an interesting situation where it's seen more commonly in that setting than in Caucasians, and it's also seen in one interesting location in the body other than on the glabrous skin. Any idea where that is?
So I know in a minority of patients, you can see it on the tongue.
Tongue is a classic location for it too. Yeah. In fact, years ago, because it occurred on the tongue where all the muscles of the tongue were located, it actually used to be called granular cell myoblastoma. And we now know that these are not myoblasts at all. We know that they're in the Schwannian family. So it's just kind of an interesting thing, but it's one of the more common neoplasms on the tongue, if you see that. Okay, let's take a look at this one.
It's Chelsea again from UT. I can do this one.
Okay.
So looking at this, it looks like a pretty superficial shave. Or
may have actually been
a punch.
Yeah, it's probably was a weak punch. We don't like people to do weak punches. We like them to plunge the punch biopsy all the way into the fat, down to the plastic. You know, you should never punch and stop before you get to that plastic, pretty much.
So with that, kind of what I can see from what we have here is the epidermis looks a little atrophic to me. It looks thinned. And then right below it, it does look like there is some extra collagen. It looks lighter than it normally would. So it looks like maybe some superficial dermal, maybe homogenization of the collagen just because it's so pink.
Good.
And then as far as inflammation, there's a little bit of, on one of the slides, I saw what looked like perivascular cuffing. It was really tight lymphocytic infiltrate against the vessels.
A little bit of that here, yeah. And then you've got some other here. What about in this area here?
Just looks scattered to me.
Yeah, it's got an interstitial pattern, which is interesting. So it's not just purely around the blood vessels. It's also in some areas, it's kind of more interstitial than perivascular, especially in this area over here. And you may not be able to see as well on this specimen, but right there, that cell, you can see a little bit of perinuclear pallor and maybe some other areas here. So there are lymphocytes here, but there are also some other cells in here besides lymphocytes.
Those monocytes or?
Well, in the skin, we call those histiocytes kind of when they're monocytes, but there's some plasma cells in here as well. So you got lymphocytes, plasma cells, an interstitial pattern. If you look up here, you were exactly correct. There is some homogenization of the collagen and the papillary dermis. And then also we look at the reticular dermis, you can see that there's some homogenization and decrease in the number of fibroblasts down here also.
Mm-hmm. So the
what
first
were
thing that I was thinking was something like early lichen sclerosis, although we'd want to see a little bit more of hyperkeratosis, but we do see atrophy of the dermis. The inflammation doesn't fit too well for lichen sclerosis because we'd see more liquefactive degeneration of the DEJ.
Well, you can actually get this pattern with LSNA. You don't have to get any kind of liquefaction. You can sometimes get some edema. And, you know, in a florid case of LSNA, you get like papillodermal edema. You can actually get a secondary blister that forms. You can bullous LSNA, and you can even get a hemorrhage into those vesicles. And it is itchy sometimes. So you do get some lichen simplex chronicus, and there may be a little bit of that here, but it's not as much. But what about the stuff going on down here? Is this a classic location for lichen sclerosis?
No.
No. What's more commonly seen when you get this pattern down in the reticular dermis?
It's not radiation dermatitis, is it?
No. Let's see if maybe one of the other sections shows a little bit better. This was a denser infiltrate over here. Well, let's just say we just had this piece over here, and you can see that here's the changes up here, and you get most of this interstitial pattern. These collagen bundles are losing the fibroblasts. So you're getting some early sclerosis of the reticular dermis also.
So maybe like a sclerodema morphea picture?
Yeah, morphea. And it's not uncommon to get morphea with features of lichen sclerosis atrophics at the top. So you get a combination of morphea and LSNA. And sometimes you'll see the patient, they just look like classic morphea. They don't really have any features of LSNA clinically. There's no whiteness, there's no follicular plugging, anything like that, but you biopsy it and it looks like this. Sometimes it looks more like LSNA, and you biopsy it and it's got, hey, there's also some features of morphea in the dermis. So just by convention, when we see reticular dermis involvement, we say there's morphea there. When it's confined to the papillary dermis, we say, well, then it's lichen sclerosis. So the two go hand in hand. They're really related entities in a way. Sometimes you get just pure LSNA, sometimes you get pure morphea, and sometimes you get a combination. Like here, we get a little bit of both. So this is a nice example where you've got features of LSNA superficially, and then you've got the changes of morphea down in the reticular dermis. And probably the morphea was the more prominent clinical presentation here would be my bet, because it doesn't have some of the changes like you talked about that you really don't see, marked thinning of the epidermis. So probably didn't have any, that cigarette paper wrinkling that we see with a fully developed lesion of LSNA. Might not really even been whitish, that kind of ivory colored whiteness that you see with LSNA. So this was probably more likely morphea, but it's a nice example where you get kind of a combination of both. If they had taken a deeper punch, it might have even been more obvious. And it's not uncommon to see little aggregations of lymphocytes and plasma cells, especially at the junction of the subcutaneous fat and the lower reticular dermis. Okay.
Okay, this is Brandy. I'm up next. So we have a punch biopsy here. And then this looks inflammatory.
Good.
Pretty isolated to the superficial dermis there.
Good.
It's at the DEJ too. So I would call it interface.
Good. Excellent. Two types of interface. Which type is this one here?
Is it like liquefactive? Is that what you're looking for?
Yeah, or vacuolar.
Vacuolar, okay.
Vacuolar, we call that, which some people call it liquefactive. I guess that's fine. To me, there are little vacuoles here at the DE junction. And so I was taught that it's vacuolar interface dermatitis. And is there anything else that we see here?
Yeah, it looks like there's perivascular infiltrate as well.
Yeah, what kind of cells are these?
I think they're lymphocytes.
Yeah, you're correct. What about in the epidermis? Any other changes there?
I think the keratinocytes largely look pretty normal. There's some like melanin incontinence.
There's a little bit of that. Are these normal?
No, I guess those are more pink than I would expect.
Yeah, yeah. Why are they pink?
Are they dyskeratotic?
Yes, good. They're dying. They're basically necrotic keratinocytes, and basically, or apoptotic keratinocytes. Basically, when they die, you get pycnosis, karyorrhexis, and karyolysis, and you get this pink eosinophilic cytoplasm. So these are dying, dead keratinocytes here. Here you've got a cluster of them over here.
Mm.
So yeah, you've described this perfectly well. There's a little bit of papillodermal edema here. What about the cornified layer here?
Just basket weave, no parakeratosis.
Yeah, perfectly normal. Perfectly normal.
Yeah.
So if you saw this patient in the clinic, what's the texture of this going to be like? If you feel it, you feel smooth, you feel scaly, crusted, or
I think it would be smooth.
yeah, it's gonna be normal. Normal, absolutely. It's probably gonna be red. You know, there's inflammation here. So it's not gonna look like normal skin. We're gonna reach out and touch it, say, yeah, there's no scale here, there's no crust or anything like that. So do you think this is been present for like maybe a day, a week, a month? How long do you think this has been present?
I would think a shorter amount of time.
Yeah, this is acute. It hasn't even had a chance to form any parakeratosis. So this is a really rapidly forming process. So what's your differential diagnosis when you get an interface dermatitis, lymphocytes, dyskeratotic keratinocytes, basket weave cornified layer? What's the diagnosis?
You could do like GVHD, or the other thing is like a variant of lupus.
Okay, what else? What's the most common of those? You see GVHD, but how common is that on a scale of 1 to 10? Unless you're bone marrow transplant hospital and you see consuls all the time. What's more common that gives you this interface dermatitis that's very acute? It's a day old. I mean, this hadn't even been present for very long. It's got dyskeratotic keratinocytes, interface dermatitis, vacuolar alteration, lymphocytes, no EOs, no newts.
Would it be EM?
Yes, erythema multiforme. So this is classic early erythema multiforme in a pretty early stage. This is beautiful. This is exactly what you might encounter on a board examination. So you need to fix this in your brain. So hit record and save this image, because this is exactly what EM looks like when you get in an early lesion. It's got everything you want here. So if you saw it clinically, it could be a target lesion. This could be this is what a target lesion would look like. If you see it. Now, if this hung around a little bit longer, you might get confluent epidermal necrosis, where the whole epidermis gets necrotic, not just individually necrotic keratinocytes here. You're getting some collections of dyskeratotic keratinocytes here. And then if it's, hangs around for maybe a week, that whole thing can slough as a blister, bullous erythema multiforme. So that's what happens in time, over the course of time. And then if you get somebody that's got a case of TEN, you get the whole epidermis gets necrotic really, really early, in that situation. They slough off widespread areas of their skin in that situation. So it's a much more florid form of this with less inflammation. Now, fixed drug eruptions is the differential diagnosis of this pattern, but that gives you a superficial and deep infiltrate, usually with eosinophils, and usually deep melanophages, because it's recurring at the same place over and over again. Now, you are right that acute graft versus host disease can look pretty similar to this. They're not going to ask you to distinguish between acute GVHD and acute erythema multiforme. Most of the case, if they're going to ask about GVHD, they're probably going to show you like the scleroderma form of GVHD, or a lichenoid form, something like that. But they're not going to ask you to distinguish between this, because, the pathophysiology of this in graft versus host disease is probably similar. It makes sense that it should look the same under the microscope. It's probably the same basic pathophysiologic process. It's an autoimmune interface dermatitis that's reacting to the epidermis that's probably gets triggered by, mycoplasma infections or, whatever the stimulus is that causes the erythema multiforme to develop. Whereas in graft versus host disease, it's you're reacting to yourself from the cells that they basically, when they put in the bone marrow transplant. So they should look the same. You mentioned one or two other things. What else did you say earlier?
I said lupus.
Yeah, lupus, this would be pretty unusual for lupus to give you this. Usually that's going to give you more vacuolar alteration. It can sometimes look like EM. What form of lupus has got erythema multiforme plus erythema plus LE associated with it? Usually a deeper lymphocytic infiltrate as well.
Is it Rowell syndrome?
Yeah, good. Rowell syndrome. And there's several other lupus-like syndromes, like Schnitzler syndrome. There's a couple others you might just familiarize yourself with those. But this is a beautiful example of EM. Yeah, lupus usually get more parakeratosis there, more thinning of the epidermis, thickening of the basal membrane zone. If you get the real acute form of acute LE, you might even get neutrophils, especially if you get, vesiculating form of LE. So that usually doesn't give you this sort of typical classic normal appearing epidermis, just with it attacks the base of it with all these lymphocytes here. Okay, so we got through 9 of them today. So we'll save the other for the next time. We'll give you another set of some others and we'll go through those the next time. Any questions? All right.